For the latest on the fight against COVID-19, we're now joined via Zoom by the head of Department of Infectious Diseases at the Helen Joseph Hospital, Dr. Jeremy Nel. Dr. Nel, thanks very much indeed for joining us. I've got to tell you, wearing my citizen hat, I'm hearing so many different things about vaccines, vaccine efficacy, and what we should do, should not do. And I just want us to simplify this because a lot of viewers probably feeling like me. So let's start with the simple terms, efficacy. How do we even measure that?
It's a really good question, and you're right to highlight the challenge with the messaging, with its new information coming in so rapidly and changing some of the original plans. Efficacy, I mean, to use a layman term, it's basically just effectiveness of the vaccine. So it would typically look at the number of, say, infections in the one arm of the vaccine of the vaccine trial who got the vaccine, and compare it to those in the same trial who didn't get the vaccine. And if you see a whole bunch of people got it on the of the group who didn't get the vaccine, and very few got it in the group who did get the vaccine, then you can guess that the vaccine works. And of course, you can be far more precise about it when you have the specific numbers, and you can calculate a percentage. So that percentage is really saying that is the chance that you get symptomatic COVID disease, that it's reduced by. In other words, if I didn't get a vaccine, or if I did get a vaccine, if I did get a vaccine, that chance of getting symptomatic COVID disease might be reduced by, say, 50%. And then that 50% is what the efficacy is.
All right, so we're getting, it sounds like quite a bit of panic actually, but I wonder if we do need to panic at this stage because, again, more variables, young people were tested, not older ones, sample size is also questioned, and so, you know, just based on that, is there need to panic straight away, or because this vaccine has been rolled out in other parts of the world already, hasn't it?
That's right. Definitely no need to panic. So the decision last night really came as a result of new evidence showing specifically the efficacy of the AstraZeneca vaccine against the South African strain that is spreading, the so-called, you know, the particular strain that's really ripping through the country at the moment. So it has been rolled out in other countries, and it is an effective vaccine against the strains of viruses that were circulating previously. However, with the new evidence, it suggests that it's very much less effective against the strain that is circulating in South Africa at the moment. So I think, you know, far from a reason to panic, I think this is a very good move to pause the rollout of this vaccine, give a chance for some further data to come in, and make a considered decision as to what to use. And that's especially important since we do have other options. You know, the Department of Health is moving forward very quickly with the help of people like Glenda Gray to get the Johnson & Johnson vaccine going in this country. And that we also have data with against the South African strain. And simply put, that seems a lot better. It seems like it offers a safer bet that it's going to reduce the amount of death, the amount of severe disease, and even the amount of overall COVID that the population gets. So when faced with these two options, I think the government has done the right thing here and moved towards an option which appears better. And again, you know, it's unfortunate that it had to be done, you know, at the last minute, but it's better than rolling it out without good proof of efficacy. Otherwise, you'd be vaccinating 1 million people or more, and it may not even reduce the severe disease all that much. And that's really the outstanding question.
All right, Johnson & Johnson, let's talk about the differences in these vaccines. I thought that they used the same technology, or is it different?
It's very similar, yeah. It's so the Johnson & Johnson vaccine is a single dose, and it's a slightly different vector a slightly different method of getting into the cells than the AstraZeneca one, which is 2 doses. So they're very similar, but not identical now. All
right, and that's perhaps accounts for the difference in the results in terms of efficacy.
All right. Sure, yeah, absolutely.
The other thing I'm curious about as well, I mean, efficacy has been measured and it's not as effective, but does that mean it's useless? Because it might not be as efficient as the next one, but can still perhaps reduce symptoms and help symptoms and that kind of thing. Is that a fair assumption?
Absolutely. And I think the issue with the AstraZeneca vaccine against the South African strain is that we do have some sort of an idea of how good it is overall for everything from the sniffles to severe disease, but we don't have a good idea specifically in the severe disease subset. In other words, is it going to keep people out of hospital? Is it going to save people's lives? But it's an unknown. It's not to say it doesn't work. It's just to say currently we really don't have that data. And the data we do have for mild disease suggests something to worry about in terms of its overall efficacy. But I certainly wouldn't, there's no evidence that it doesn't work yet. We just don't have that evidence. Whereas we do have better evidence for vaccines like the J&J vaccine.
All right. So a lot of people going crazy today about how could we do this. There was nothing else we could have done, I guess, because the information came post the fact.
Absolutely. I mean, this information has come in the last few days only. And I think, I work on the front line. I want the vaccine more than almost anyone in this country at the moment. But I think the right decision has been made. I think that it's a pause on the AstraZeneca vaccine. It's not to say it's useless, not to say we're not ever going to roll it out, but pause for now when we have the J&J vaccine, which is imminently available here. And we really could be rolling it out in a matter of days, potentially. And I think that is the better decision here. This is a safer decision. This is a decision which is more conservative, arguably, but which is more likely to guarantee us getting the sort of protection that we really need in the country, namely from severe disease and from people dying. And I think that's a good decision for now, but it'll be revisited as more data comes in. I fully support it, and I would have done the same.
Okay, so Chad have just received the China vaccine, and the question now becomes, is that going to be part of our basket of solutions? Russia has had theirs, I believe, peer-reviewed, and that's 91% effective. Are these other solutions that we're going to bring into South Africa? And maybe it's a bit naive of me, but I'm thinking the Chinese probably know this virus a lot better than most people.
So in the case of the Russian vaccine, the so-called Sputnik vaccine, that has now been published in a good peer-reviewed journal, and that really does seem like one we can add to the potentials in terms of vaccine that we could be getting in this country. For the Chinese vaccine, it's not yet been properly published in a good journal. We have provisional assessments of data. I think it needs to be further published out in the open so we can see those figures. But if they look good, there's no reason why it couldn't be incorporated into the South African staple too. We're lucky in that we've got now 6 vaccines from various companies, which all have shown efficacy to some greater or lesser degree. So we really are getting to the stage where more and more options are coming on the table, and that's a good thing for South Africa and for the world. The more options there are, the more people can get vaccinated quicker.
All right, and I guess also we're learning as we're going along, because we were talking about these 2 doses, when do you take them, and it sounds as if the second dose should be a bit further down the line now than was first believed, because it's more efficient. And this is going to be the game for some time, isn't it?
Absolutely. So the second dose, that's really for the AstraZeneca vaccine. And that does suggest, new evidence does suggest that later delaying it to up to, say, 12 weeks is better than giving it after 3 or 4 weeks in terms of efficacy. With the Johnson & Johnson vaccine, we're lucky in that it's actually only a single dose. So that question is less of a problem. But you're absolutely right. People are learning more and more. These vaccines have been done incredibly well, these studies. But it's still new, and we're getting more information as they are rolled out and as the more data comes in. The good news is that all of them are exceptionally safe. That's really such good news. I mean, you're looking at severe reactions as a result of the vaccine down to basically 0%, not a single death from the vaccine in the entire world. Many of them have been rolled out to millions of people. So these vaccines are safe, and really the only question, and the reason South Africa is going with J&J and other companies rather than AstraZeneca, at least for now, it just comes down to efficacy. How good is it going to be at preventing hospitalizations and death? And we have better data on some of the other ones, which is why we're going with one of them for now.
All right, so final word, no need to panic. Government's done the right thing to pause the AstraZeneca for now.
Definitely no need to panic. This is a good move. This is actually a conservative move that, if anything, will help us get a better result out of the vaccination program. I fully support it, and I think that this is what I would have done too, where I would choosing. Absolutely.
Dr. Jeremy Nel, thanks very much indeed for some reassurance as this debate rages. Thanks so much indeed for your insights.